Welcome to another EduMed video, and in the series of videos talking about intensive care ward rounds, we'll talk about the L in the ABCD approach, which is for lines. We'll talk a little bit about peripheral vascular access devices, i.e. cannulas, central vascular access, arterial lines and PICC lines. The general principles in intensive care are: get any extraneous vascular access device, be that a peripheral line or especially a central line, out as soon as possible. All of these things are sites for infection. Peripheral lines are far more preferable than central lines, but sometimes there are drugs that the patient is on, like TPN or vasopressors or inotrops, that can't be given peripherally, and so for those patients, central access is necessary. Always think about whether a drug needs to be given in IV or can it be given enterally. If a patient is absorbing their feed appropriately, it's likely they'll be absorbing drugs appropriately. So the common one is paracetamol. There's no need to give this IV. If we've got an NG tube in, you can give soluble paracetamol through an NG tube. So always rationalize the medication that you're on. Always monitor the lines, see how long they've been in for, and look at the skin around them whenever you examine a patient. They are the number one cause of iatrogenic infection in patients on the intensive care, and as such, we really do need to be careful about leaving them in for too long, and if there's any evidence of infection, have a low threshold for taking it out and putting in a new line. If there's rising inflammatory markers, always think about the lines. Make sure that they're not older than at least 5 days, or in the case of peripheral vascular access devices, 3 days. Peripheral lines are sometimes more preferable to central lines because you can pick up infection much more quickly. They're much more superficial to the skin, so you can see the erythema, the thrombophlebitis and the cellulitis that occurs much more easily, and when they become infected they're more likely to become tissued and therefore stop working. For that reason alone, they're going to cause less bacteremia, but also with the biofilm that occurs from the outside of the vascular access device through the plastic parts of it. You can imagine how with a central line, which sits just at the junction of the superior vena cava and the right atrium, you can get bacterial biofilm growing all the way down those central lines and sitting right next to the heart where the valves are, and so increasing the risk of endocarditis significantly. This is often got to be balanced with the fact that, especially in intensive care where patients may have been in intensive care for multiple weeks, months or even years, it can be difficult to place peripheral lines, so we do need to balance the risk of not being able to get any IV access with trying to use peripheral access. So if patients are on 4, 5, 6 or more infusions, even if they can all be given peripherally, you might find it difficult to be able to find that many cannula sites. And so for those patients where we want to save the vascular access points, we might elect for a central line with multiple lumens. In terms of central lines, there are 3 main sites that we put them in, and they are the internal jugular, the subclavian and the femoral. Now, generally speaking, the internal jugular is the one that most people prefer, which got the lowest risk of infection compared to the risks of pneumothorax. Subclavian actually has a much lower risk of infection. However, it's got a higher risk of developing pneumothoraces, and especially in patients who are positive pressure ventilated, there is a risk that you could nick the pleura and therefore cause a persistent air leak leading to a pneumothorax. And finally, femoral, which is often the most dirty because it's harder to clean, it's in the fold of the skin, and also with the patients opening their bowels and potentially having urine leaking around their catheters, it can get quite dirty. So if we try, if we can, to go for internal jugulars where possible. There are a few times where femorals are preferable, such as in patients who have intracranial disease, where you want to try and avoid impedance of the venous drainage, but for the most part, internal jugular is our number one site to go for. PICC lines are peripheral lines in the sense that they're put into peripheral veins, but they're very long, and the tip of them usually end up in the superior vena cava. And so they can be used as central lines, and so things like noradrenaline can go through them, and also TPN. They're preferable to central lines in the sense that they are placed peripherally, and therefore if you do get infection, it is often fairly obvious fairly quickly that they're infected. Occasionally you can just get the infection on the tip and nowhere else, but that's rare. They can block much more easily than central lines, however, because they're much smaller bore to be able to fit through a peripheral line as a peripheral vein, as opposed to through a central vein such as the internal jugular. And always be wary of PICCs because they can form thrombus around them, and if they do, patients can end up with deep-seated venous thromboses in deep veins in the arms. And so swollen red arms, always think about DVTs in patients with PICC lines, and if they do have it, take it out. Arterial lines are essentially cannulas, but rather than being put into a vein, it's put into the artery. The main arteries that are used is the radial artery. Sometimes we use the ulnar artery, but it's always worth checking the blood flow to the hand before doing that. And we do that through something called the Allen's test, which we'll go through in our talk on arterial lines. Femorals are sometimes used, especially if the radials are difficult to get to, or for certain special types of arterial lines, such as PICC or cardiac output monitoring arterial lines. Brachials are generally avoided because the brachial artery is an end artery, and so you do run the risk of causing ischemia to the distal hand if the brachial artery develops a thrombus, or if you damage the brachial artery whilst trying to put an arterial line in. Another useful area to put an arterial line in is in the dorsalis pedis, just at the top of the foot, where if you've got difficulty accessing the ulnar arteries, that is a good place to look. However, a lot of patients can have peripheral vascular disease, and so you can get false readings from these. So in general, you should try and assess the insertion sites of all vascular access devices on a daily basis. Femoral sites are classed as generally more dirty than the other sites, so ideally try to go for the internal jugulars if you can. The mantra of if you don't need it, take it out holds very much for lines. And peripheral lines are preferable to central lines, so always try to put in a peripheral line where you can.